Hola a todos y gracias por la invitation. I would really like to thank the organizers of this very exciting meeting for inviting me to speak on optimizing peritoneal dialysis in critically ill patients. My name is Mignon McCulloch and I'm based at the Red Cross Children's Hospital in Cape Town, and this is work that has been done by myself, my colleague Peter Norse and the rest of our team. A little while ago, there was an interesting pediatric dialysis survey which looked at availability of dialysis across the world. And what was very clear is that peritoneal dialysis was available in all centers. If you look at this table, the availability of renal replacement therapy in the form of PD was available in both developing, now known as low middle income countries, as well as developed, which is high income countries across the board, compared to CRRT, which was interestingly only available in 60% of high income countries and a third of low middle income countries. In our setting, putting a bedside PD catheter, as can be seen here, is really quick and easy. We can get it done in 15 or 20 minutes. Whereas sending patients to theatre for a surgical PD catheter or a surgically inserted hemoline may take a lot longer. The ISPD guidelines, which were put out in 2014, looked at PD for acute kidney injury. And in an attempt to make this a gold standard for everybody, the first recommendation is that any child who needs dialysis for AKI should be transferred to a pediatric renal center if at all possible. Failing this, attempt should be to get a surgeon to place a Tinkoff catheter. But if neither of these are a possibility, then putting in a bedside PD catheter is the next recommendation. And what we say is that if you can do or have ever done an ascites tap, then doing a PD catheter at the bedside should be as easy, provided you follow some basic guidelines. So just to remind everybody about the practicalities of PD, the prescription, we normally start off with 10 to 20 mils per kilogram of fluid per exchange, and we adapt this to the ventilatory requirements of the child. Dialysis fluid, there's a varied number or variety available, so the easiest probably lactate buffered, such as Dialysis, but increasingly we're using bicarbonate based, such as Bicavera, although this is not easily available in some very low income countries. Again, to remind everyone that there are three strengths: weak, medium, and strong, and they're slightly different compositions depending on where you are. But we've also started teaching homemade solutions using agents like ringers, lactate, and 50% dextrose to facilitate having some form of dialysis fluid if nothing else is available. The cycles that we use are filling, dwelling, and draining, and on the whole we fill quite quickly, 10 minutes, drain depending on the catheter over 20 minutes, and then the dwell, depending on why you are doing the dialysis, can be anywhere between 30 and 90 minutes. So just a reminder of the recipe we use. So some kind of buffered agent, we use Ringer's lactate, but Plasmolite B and Belsol have also been used. And we are not too concerned about the potassium in this, as it quickly equilibrates. We then make up 3 strengths of fluid by adding varying quantities of 50% dextrose depending on how much fluid overload your patient has. And this is very similar to the lactate-based PD solutions. If you're lucky enough to have the bicarbonate, which we do now, then that would be a more optimal dialysis fluid. So the practicalities of bedside inserted PD, most people would say, yes, but you have a very high risk of infection. And for this reason, we emphasize that you need to be sterile. If you can't take your patient to the operating theatre, then bring your operating theatre to the bedside. Make sure you wear your proper PPE, which we now are very used to after the COVID pandemic, and make sure your patient has got a sterile environment. We also appoint someone to do the airway management, as it's difficult to put in a PD catheter and manage the airway. And very importantly, remember to empty your bladder, as putting in a PD catheter into a full bladder is really not ideal, and there are easier ways of emptying a bladder than putting in a PD catheter. We also give sedation. We tend to use ketamine and midazolam, but that would be depending on what your local center has available. And then we also use local anesthetic together with this. Really important, if your patient doesn't have a lot of ascites in the abdomen, important to create some artificial ascites by running fluid such as saline or your Ringer's lactate into the abdomen before you start inserting your PD catheter. And we use that same needle to do the Seldinger technique that we have infiltrated with fluid. So fluid prescriptions, if you're fluid overloaded, you're going to increase your glucose solution. If you solute overloaded, such as hyperkalemia, then you're going to increase your frequency of your cycle. We add heparin, somewhere between 500 and 1,000 units per liter. We also add antibiotics, initially intravenously, a single dose of vancomycin, but if we send the peritoneal dialysis fluid off for microscopy culture and sensitivity, and if there are cells or evidence of a peritonitis, we would add antibiotics into the bag, and it depends on what your organism sensitivities are, depending on what you add. For neonates and for liver failure patient, if possible, better to use bicarbonate-based fluids. And then what PD catheters do you use? Well, this is where the art of medicine comes in, and if you don't have peel-away PD catheter or your multi-purpose catheters, we have seen people use any manner of device such as venous cannulas. Chest drains have been used in Nigeria, nasogastric tubes have been used in some parts of Africa. Increasingly, we are suggesting using a venous central line, such as your adult central line. These are bigger catheters and they have an in and an out port. We have peel-away Tinkoff catheters available and also flexible multi-purpose drainage catheters. But you can see in 2007 this paper came out, and it suggested that whatever you can use, you should try and use. So just to show you some pictures, the little 5 French Cook catheter has been discontinued quite some time back now, and this year they are going to be discontinuing the 8.5 French PD catheter, which is really a shame, but we do have an alternative. As I've shown, you can use a central line, preferably an adult central line, because a pediatric 4 or 5 French blocks easily, so we would recommend an adult somewhere between 8, 10, 12, or even bigger if you've got that available. In neonates, some people have used venous cannulas. This is a surgical Tinkoff, and then this is the stick catheter or the Romson's catheter, which is really cheap and easily available in many low-income countries, but it is a very long, very sharp stylet, and you do need to have some skills. If at all possible, I would try and avoid this, as it is not inserted by Seldinger technique and can cause damage not only to hollow viscuses, but also to venous, veins and arteries, which can cause catastrophic events. At present, we recommend the new generation Cook catheters. We are using these in our ICU already for chest drains, pericardial drains, and ascitic drains, and we've now started using them as PD catheters as well. They're not strictly licensed for PD catheters, but we're hoping that they will be with the discontinuation of the little Cook PD catheters. And then, of course, the peel-away Tinkoff catheter, which is becoming increasingly popular. Seldinger technique, you put in a needle, you then put in your guide wire, take your needle out, thread your stylet and dilator over your guide wire, take the blue stylet out, take your wire out, and then thread your Tinkoff catheter through your device, which you then peel away, and you then have a bedside inserted peel-away Tinkoff. This is a picture from a colleague in the Philippines showing the use of a large adult central line with an in and an out port for neonates. So if you've got nothing else, usually people do have adult central lines available in their hospitals. Then moving on to the actual dialysis. So we use manual dialysis. Here is our dialysis fluid bag. Buretrols running into the patient with a fluid warmer if it's cold, and then running out into your drainage bag. A couple of the dialysis companies have now come up with their own custom-made PD closed sets, with an in port and an out port draining into your bag. From our point of view, what's really important is measuring how much fluid goes in and how much comes out. So if you have nothing else, using a venous access line together with a Buretrol and a wire T-piece can be manufactured in a homemade device. And a lot of people would say that PD is quite low tech, but if you see, this is one of our cardiac surgical patients who is actually on nitric oxide, on an oscillator, multiple infusions, and hanging over here is your PD fluid as well as PD. A lot of centers would electively place a PD catheter for any cardiac surgical cases so that PD can be started quite early on. So PD not always low tech. We are fortunate we've got automated dialysis machines which we can use for children over 5 kilograms, and this then saves a nurse. We increasingly have now also got the Claria machine, which has got a modem, and you can actually do this by remote control. So this is well known for chronic, but we are also using this for acute PD in our ICU. So here's a patient with hemolytic uremic syndrome receiving PD using the cycling machine, which at least then relieves a nurse of the work of having to chart in and out fluid. So I've currently done an audit of all our PD catheters inserted in our ICU for acute kidney injury over the last 15 years, and we've done over 500 cases using either our Cook or Cómo acute catheters. We've had manual for the little guys, automated for the bigger children. We've had a combination of Dialysis and Bicavera, and in the early days, before we had Bicavera available, we used homemade fluid solutions with Plasmolite B or Belsol. We've had an extremely low infection rate, and I'll come back to that. And our survival for these children has been 60%, which is comparable to patients requiring conventional CVVH in other centers. Interestingly, our duration of dialysis in the majority has been less than 4 days, so 66%, and if you look at under 7 days, 80% have been less than a week. So this is for acute kidney injury, so very few have actually gone on to need dialysis for anything more than 14 days. Very few of our patients have gone on to develop end-stage CKD. Looking at our types of catheters, the commonest has been the Cook, either the PD catheter or the Cook multi-purpose catheter. We've used a quarter of our catheters have been Piloway Tenkov, so we've actually had very few surgical catheters that have needed insertion by the surgeons. And then in those kids where PD has failed, we have had the facilities to go on to CVVH in 10%, just under 10% of cases. We've also had the Carpe Diem available for our neonates, but as you can see, we're a PD first center, both for chronic but also for acute kidney injury. Then I showed you the 2014 guidelines, and we've just updated the ISPD guidelines for AKI for both adults and pediatrics. And this is the one paper that is really worth perusing, as it has all the recommendations, all the recipes, all the kinds of catheters that you can need, both for high-income countries as well as low and middle-income countries. Just a little bit of time on locally made fluids. So in Cameroon, they started using locally made solutions in their pharmacy versus commercial fluid. And as I mentioned earlier, everybody always gets very anxious and said, what about your peritonitis rate? And you can see with commercial solution, they had 16%, and with their local made solution, they also had 16%. So if you are very careful using a sterile technique, this is not normally a concern. We have replicated this in pediatrics, both at the Red Cross Children's Hospital, where we only had a 4% peritonitis rate, and similarly in the DRC, Pepe Ukule also did a similar study with very similar results. So if you're careful, if you do everything in a sterile manner, locally made fluid is definitely a possibility if you've got nothing else available. My changes in my practice in Africa, and actually when I've done teaching in Asia and also in some parts of South America, if you've got a 3-way tap, you can improvise with anything, and increasingly if you've got a Buretrol where you can measure how much fluid goes in and how much comes out, it really makes your life a lot easier. And this is a picture of a system whereby you've got Ringer's lactate, which has been made up with some dextrose, a 3-way tap, and then a nasogastric tube with some increased holes, and then a drainage bag. So this is the very basics that you would need to perform PD. Other centers have sent me pictures. So this is the stick catheter, the Romson's catheter. But as I said, please be careful of that very sharp stylet. You really need to place this very carefully. And in babies, this can be a big challenge. These catheters often fall out and they don't allow the patient to be very mobile. This is a picture of a little baby that has got an adult central line, and that seems to work quite well. And then I'm just going to mention continuous flow peritoneal dialysis, and this is quite exciting work that is happening, driven by Pete Norse at our center. So we know that PD is good. Specifically, it's cheap, it's good for small babies, good for patients with hemodynamic instability, disturbed coagulation, and those where venous access can be really a challenge. But we do know that both HD and CVVH has far better clearance and fluid removal. And if you look historically, CFPD in Boston in 1945, they used a continuous flow technique in AKI with 2 catheters. And they, in those days, used glass bottles. They had Tyrodes solution, where they used a solution similar to Ringer's. They added some glucose and bicarb, and this was published in the Annals of Surgery in 1948. So CFPD, as a form of PD, you maintain your highest possible solute concentration gradient at all times. So your PD solution, you mix your dialysate fluid, you maximize your time by minimizing your exchanges, and the procedures were developed some years ago, but they were abandoned because of the expense of running lots of fluid in, but also of the catheter technology, which just did not keep up with peritoneal dialysis. But recently there's been a renewed interest that it can be very useful for AKI, and as I've mentioned, in children, specifically low middle income countries. And the feeling was that we needed larger studies in peds with higher volumes, flow volumes, and improved catheter technology. And it is suited for acute PD in children, not for chronic, because you use small volumes, you've got a limited amount of time, and often your volumes of infusion are large related to your body weight. So what do you need? You need 2 PD catheters. They can be the same or they can be different sizes. We've used mainly bedside inserted Seldinger, but you can also use surgically inserted PD catheters. Important that they don't leak, so attention to detail when inserting the PD catheter. And these are often for urgent start PD, so you don't have the luxury of waiting 10 to 14 days for the PD catheter to settle in. This is a catheter that needs to go in and be used immediately. The fluid that can be used for PD can be either manufactured or locally made, and you can use either dialysis machines or manually gravity assisted. So I'm going to talk you through what we've done at the Red Cross Children's Hospital. So firstly, 2 PD catheters. So one was a Cook catheter in this picture, and one is a bedside peel-away Tinkoff, placed in the midline. The second one was then placed somewhere between your superior iliac crest and your umbilicus. And this was published in the beginning, so you can see one catheter there and one catheter there. You should try and separate the catheters as far as you can, with one pointing downwards and the other one pointing away, dedicated for outflow. We've had a lot of our training fellows inserting these PD catheters, and you can see here's 2 Cook catheters being inserted in 2 different positions in the abdomen. So you've got your double PD catheters, and we actually then connect them to the PD drainage set. In the beginning, we used the old BM25, which is a CVVH machine, and we could use full volumes again, as I've said before, 10 to 20 mils per kilo. Your inflow of 100 mils per 1.73 meters squared, and your outflow is slightly faster so that you don't accumulate fluid in the abdomen and get a distended abdomen. This worked quite well because from a safety point of view, we had a transducer measuring inflow and outflow pressure, and we set the limits at the lowest setting on the machine. In an attempt to ensure safety for the patient, we measured the abdominal circumference, but we also measured the intra-abdominal pressure by using the bladder catheter as a surrogate for pressure, and that worked quite well. However, with time and technology, the newer machines can't be adapted and adjusted for CVVH machines being used as PD. And so we've had to think differently. But in the beginning, the range of patients were quite young, under 30 months, under 14 kilograms, and mainly either shock and sepsis or cardiac surgery. And the outcome of conventional PD versus CFPD, you can see your ultrafiltration rate in study 1 much higher with CFPD, and your clearance of your urea also much higher in the study 1. Study 2 increased your ultrafiltration to 6.7, so using the previous 1.8 as your baseline and then increasing it even more. And you can see with this your clearance increased even further. What were the complications while on PD? Well, sometimes there were flow challenges where the system wouldn't flow, so then we would swap the in and out flow PD catheters around. On occasion, we had hypoglycemia, and then we commenced an insulin infusion. Hypokalemia in some patients where the potassium came down really quickly with a peritoneal dialysis, so we then ironically had to add potassium to their PD bags. And when we saw intraperitoneal pressure rising, we would then drain more fluid from the abdomen. So as I mentioned, we measured the bladder catheter pressure as a surrogate for intraperitoneal pressure. And the conclusion from this initial study was that CFPD is safe, improves ultrafiltration and clearance. Technologically, it was quite heavy, needing technologists to operate the machines. The pumps were expensive, and these were too fast for most intravenous infusion pumps. And so the thinking was to develop a simpler way of doing CFPD using gravity to be used in low-income countries. And here you can see a picture of Pete Norse together with Stefano Picker and Tim Bunchman in our dialysis unit at Red Cross, just thinking about how we could actually use this just using gravity without using cycling machines. And here's a schematic picture of the dialysis fluid with a Buretrol measuring how much fluid goes in, and then this is your out port measuring your pressure, but also a drip chamber draining into a collection bag, and then this fluid being weighed on a scale for accurate measurement. So continuous fluid running in and continuous fluid running out. So this is the real picture of the gravity-assisted PD, and you can see lots of use of Buretrols and three-way taps. As I explained earlier, these are now available in most centers. Here it is in action with Pete Norse and Beatrice Nine, one of our fellows from Ghana. And their safety issues were that the height of the delivery bag was as low as possible. We also did hourly measurements of intraperitoneal pressure, tidal volumes and drop rates, and also measured the glucose. Here you can see measuring manually the intraperitoneal pressure. And the results were the gravity-assisted. So previously I showed you the machine-assisted, gravity-assisted, ultrafiltration, again much better with CFPD, again clearance of urea much better, creatinine clearance also much better with a CFPD. And when we increased this fluid rate to 50, we got even better CFPD ultrafiltration, as well as urea and creatinine clearance. So the conclusion from this is that CFPD allows for not only clearance of solute, but also improved ultrafiltration. Gravity-assisted CFPD is successful and safe with low cost and very light technology. Practically, it can be used interchangeably with your normal conventional PD if you need increased ultrafiltration. A suggestion that even for the use of hyperammonemia and your inborn errors where CVVH is not available. We swapped from the Cook PD catheter to the multi-purpose Cook catheter successfully, and just to be important that you can increase albumin losses, and so just to improve your diet when you're on this form of dialysis. So in closing, my take-home message is that prevention of AKI is your first priority, but that no patient with AKI should die without an attempt of PD. So either a surgical or a Tinkoff catheter is obviously your gold standard, but homemade fluid and improvised catheters can be used if you've got nothing else. So in our center, we do have surgeons and Tinkoffs, but we are also aware of the fact that many of the fellows we train go back to settings where they would need to make their own homemade fluid. Neonates is a specific group where dialysis can be a challenge, so we are fortunate we do have a carpe diem, but we also realize that PD in that setting, as a PD first with acute start, can be a lot easier than trying to get venous access in tiny infants. Important message for everybody: you can make a difference wherever you are, and watch the space for CFPD. There's definitely an increasing role in pediatric nephrology, also in high-income countries, especially in small infants where venous access could be difficult. But do what you do best. And just a few slides on the Saving Young Lives program, collaboration of these 4 organizations. We've used, Brett Cullis introduced us to a pork belly, and so we've used this for training. We've shown that learning is fun, both for PD but also for CVVH. We've trained teams of doctors and nurses so that the nurses understand what we're trying to do when doctors want to start a newfangled therapy. This was the last in-person Saving Young Lives course that we ran at Red Cross, but we've also run lots of workshops at various congresses, initially in person, but also virtually. Just to remind you that this is a really great guideline with all the practical tips on how to manage AKI with peritoneal dialysis. And then just in closing, to invite you, sadly not in person, but to our virtual World Federation of Intensive Care and Critical Care Societies Congress in July, also the IPNA Congress in September. And for my closing slide, this is good news for Africa, for India and the world, that we can use PD when nothing else is available, and sometimes PD first actually has pretty good results. And I just want to thank all my colleagues at Red Cross Children's Hospital for the work that we do, specifically for Peter Norse and also the ICU team. Thank you for your attention, and I look forward to any questions.